Well, good afternoon, everyone, and welcome to Trust for America's Health, Age-Friendly Public Health Systems, or AFIS, October training, partnering to enhance equitable services for older adults. We're very happy you're here to join us today to learn more about how the public health sector can support older adult health and well-being. My name is Megan Wolf, and I'm joined today by my colleague, Dr. Karan Phillips. And the APHIS movement would not be possible without the generous support from and partnership with the John A. Hartford Foundation. Next slide, please. So we ask that you all please keep your devices muted during the presentation so we can avoid any background noise, but do feel free to put your questions in the chat throughout our presentation today. And there will be time at the end for questions, but we might find that we want to entertain some questions during the presentation as well. So we'll just play it by ear on that front. And next slide, please. So your feedback is always very important to us. So we would ask that at the end that you would take the time, just a couple minutes, to complete an anonymous feedback survey that will pop up on your screen at the end of the training. Your insights will be shared with our evaluation partner at the New York Academy of Medicine and will really help us to enhance our future trainings. Next slide, please. For those of you who are new joining us, and it's probably not a lot of you, we have a lot of repeat participants, but for those of you who are new, TIFA, Trust for America's Health, we call ourselves TIFA. We're a public health policy research and advocacy organization dedicated to optimal health for every person and individual. TIFA produces several reports annually, including Ready or Not, which focuses on emergency preparedness, Pain in the Nation, which focuses on the deaths from suicide and drug and alcohol abuse. And then related to healthy aging, we've produced reports on several topics, including housing, rural healthy aging, and the one you see on the screen here is our most recent brief that discusses the alignment between our APHIS 6Cs framework and the 10 essential public health services. So we're really proud of that piece of work and commend it to you. So next slide, please. So this year, our monthly trainings have all had an equity component. We're really trying to focus on equity, which is really at the center of our APHIS 6Cs framework. So today, our guest speaker, Katie Adamson, who I've known for a long time in this role and in previous roles, but Katie is Vice President for Health Partnerships and Policy, Government Relations with the YMCA. And she'll be talking about some of the programs that the Y is involved with that support older adults and some opportunities for partnering with public health. So Katie, I will now turn this over to you. I hope I didn't mangle your title too badly.
Oh, no, perfect.
Okay, great.
Absolutely perfect. So thanks so much, Megan. I wanted to first start out by giving you a little bit of background on the why. We've spent about the last 20 years laser focused on efforts to tackle obesity and chronic disease, and we've done that from multiple angles. And that's important to the conversation today because, as you know, the older adults are more likely to be at risk for or living with a chronic disease. Research from the National Council on Aging tells us that 95% of older adults have at least one chronic disease, and 79% have two or more. So the Y is working to address many of these chronic diseases, including hypertension, obesity, arthritis, diabetes, prediabetes, and cancer, and is working on new models in other areas like dementia and Parkinson's, and an age-friendly cohort, which I will talk about later. We're also working on the health-related factors that contribute to poor health outcomes, also often referred to as social determinants of health. So I hope that when I share this with you today, you'll have a better understanding about the why as an organization and our work to identify ways that we might want to work with you and how you might want to work with our local Ys. So next slide. I'm going to share with you again more about the Y as an organization, then how we're approaching and addressing health-related social needs, social determinants of health in sort of the four core areas, and then our new healthy aging innovations cohort that we have underway. Next slide. The best way I can tell you about this work is from my lens at the Y and our work as a community partner in advancing health and health-related social needs. Our physical footprint 20 years ago really demanded that we do more to improve the community's health. 73% of US households live within a 10-mile drive of a YMCA, and our wives serves 10,000 communities through 2,600 branches that don't just serve their community directly around them, but actually go out and serve other counties and communities. We've been advancing policies, programs, and systems change to promote the community's health for the last 20 years. And our model at the Y is federated, which gets complicated because it means that YUSA can incentivize our Ys and drive innovation, but we can't tell them what to do. Next slide. So today the Y serves 17 million community members. 3.6 million of them are 55 years of age or older. This number was 4.5 million before the pandemic, but it's coming back. This older adult population has been our fastest growing population in the YMCA over the last several years. And we serve slightly more men, or more women than men. And have for some time, just a little bit more. And I say that because everyone asks me, are we affiliated with the YWCA? And we are not. But we do collaborate with them often at the federal, state, and local level. They're good friends and partners. Next slide. So our national CEO shut our doors even before the public health community called on organizations to do that during the pandemic. But we didn't stop our work at the YMCA. While individuals were not utilizing our health and wellness spaces, we converted those spaces to emergency childcare for frontline workers, and we provided over 100 million meals to our communities, and we partnered with CDC and others on vaccine education and awareness. We went from 19 million members in 2019 to 11 million members in 2020. That meant a substantial loss in revenue to our YMCAs. We organized at that time in 2019 with a nonprofit community through our government relations office to grow a coalition called Relief for Charities, and we were able to get nonprofits added to the famous PPP loans. Had we not done that, and a lot of folks don't realize there was actually an effort to do that, most nonprofits wouldn't have survived the pandemic. So we are rebuilding our capacity at the Y, and like I said, we went from 11 million, now we're back up to 17 million in just a few short years, and we'll continue to come back. But we were hit hard by closures and lost about $4 billion in revenue collectively across the YMCA. The PPP saved us, but we lost a lot of our health and wellness staff during that time, and those programs took a hard hit. But again, those folks are coming back, and we are retraining and re-onboarding those staff to be back in our facilities. Next slide. So now I'm going to pivot and talk to you a little bit more about how our Ys approach health-related social needs. So next slide. So this is a little complicated, but it's actually, I took a bunch of stuff out of it to make it a little less complicated, but this is the WISE version of the socioecologic model for folks in public health didn't know that term. We work from the individual level all the way to the societal level, and we work on primary, secondary, and tertiary prevention programs. But most people think of our Y for our work in the upper left-hand corner, and I promise you, we are more than gym and swim. We are working in all these spaces because you cannot truly influence a change in health outcomes without this broader approach of working both with individuals, families, organizations, community, and then the larger society. We're fortunate enough to touch individuals and families across the entire lifespan. We are a very large organization, and changes within our structure can impact not only millions of lives, but the larger communities that we serve in. We have partners who we can nudge to do the same and join us in our strategies for having a bigger impact. Our cause is really to build stronger communities, and because of our local, state, and national footprint, we can work with partners at a societal level to create higher level change that can impact health outcomes. And influencing health requires us to work and respond to those who need us today, sort of more on the program level maybe, but also to work upstream and tackle some of those health-related social needs upstream so that we can improve societal conditions and improve health outcomes before they even happen. So to prevent health outcomes, poor health outcomes before they even start. Next slide. Next slide. There we go. So whether or not you're calling it the social determinants of health or health-related social needs, I imagine this image is old to many of you. This slide tells us that 80% of health is influenced by factors in the community, and that 20% of health outcomes are impacted by the formal health setting. The Y is working on all fronts, on socioeconomic factors, the physical environment, helping to support lifestyle health, and integrating with the formal health system. Next slide. I find that I surprise a lot of people when I share these statistics. We are the largest provider of childcare, after school, summer camp, and swim lessons. We are also one of the largest provider of summer supper and after school meals to kids, and provided over 110 million meals to kids in the last 2 years in a partnership with USDA food programs. And 300 of our Ys are working directly on providing meals to older adults. We are a large employer. We employ more than 270,000 full and part-time employees, and we're one of, if not the largest employer of youth. We provide housing services at 182 of our Ys, and including 15,000 beds a night. We drive strict standards and have an accrediting process for our YMCAs for child protection and safety from sexual abuse. And we are really focused on community mental health and social connectedness as we speak. It's a big driver for us right now. Next slide. You can see from these numbers going down the slide here that the Ys are working with older adults. Most of our Ys are working with older adults. In fact, of the 2,600 Ys that we have, far more than half are providing opportunities and offerings for social gathering programs for seniors. More than half are offering older adult programs to improve their physical health. And most of our Ys contract with multiple third-party aggregators to provide fitness benefits to Medicare beneficiaries. We offer aquatic programs and swim instruction. And as I mentioned earlier, many of our Ys are starting to offer mental health programming and food programs to older adults. So let me switch now, next slide, to our work on the physical or built environment. And so you can go one more slide. And this is more of a historical perspective, but I will tell you that we're going to relaunch this initiative. So over a 10-year period, the Y was able to partner with CDC, Robert Wood Johnson Foundation, and thousands of partners on the ground to advance policy systems and environmental change. These changes created opportunities at the community and state level for healthy eating and physical activity aimed at where people lived, worked, learned, and played. This was done through several foundations and federal initiatives, and we called the body of work our Healthy Communities Initiative. Next slide. The model of this initiative really was where we pulled the highest level of policy leaders across multiple sectors, from mayors to president of hospitals to presidents of the Chamber of Commerce and food program providers, agricultural secretaries, school superintendents. We brought them to a table and said, what policy levers can you move to strengthen the community environments where people live, work, learn, and play? This was our work in healthy communities. Next slide. And over the 10 years of work, we tracked the changes that we made in communities. And at the community level, we made more than 39,000 changes that impacted up to 73 million lives. And at the state level, we were funded separately at the state level by Robert Wood Johnson Foundation, and we were able to impact up to 150 million lives. And how do we do that? What kind of changes am I talking about? I'm talking about putting PE and recess back in the school day, improving the school lunch program, building farmers markets or grocery stores in communities. We improve school meals, built bike paths and trails that connected the community, crosswalks and countdown timers in heavily trafficked areas, support for safe routes to school programs, working to get health systems to pay for evidence-based health interventions, and after school sites adopting healthy eating and physical activity standards, not just at the Y, but at all after school environments, so that any child would go to any after school program would have a healthy environment. Next slide. And over the past 8 years, we've worked on reports and projects with friends in this community, including the Safe Routes Partnership. And we developed a report called Making Strides that anybody could use. And it tracks and scores states on policies and funding and processes that support walkability and rollability, and really universal design, so that no matter whether you're in a wheelchair or in a stroller or walking or biking, you have great routes through the community to be able to be physically active. Next slide. So I'm going to shift to our group-based, evidence-based behavior change programs and share with you how we've been getting health systems to partner with us and change the focus on how we can better prevent and control chronic disease and injury. Next slide. So the biggest ever federal investment in a lifestyle health program looked at diabetes prevention. It was run out of NIH with CDC as a lead partner, and it compared the effectiveness of a lifestyle intervention to a drug for the prevention of diabetes for those living with prediabetes. The trial was called off early. That was back in 1996, when it was learned that the lifestyle arm could by double reduce the incidence of diabetes among people with prediabetes. For adults with the lifestyle intervention, they could reduce their incidence by 58%. And among those over 60, they could reduce their incidence of diabetes by 71% if they achieved 5% weight loss of their body weight. But did that program scale in 1996, even though it was called off and told to scale by the secretary of the time? No. It was too expensive, and there was no delivery system in place to scale the program. So universities involved in the trial came to the YMCA and asked if we could deliver the program in the community more affordably and try to scale it nationally. Next slide. And why was it important to scale this program? So when I look at, a slide like this and I hear a tip of the iceberg, I think sometimes that term can be overused, but not when it comes to diabetes. So today, 38 million people live with diabetes and 98 million people live with prediabetes, including 1 in 2 older adults. Let's put this in some cost terms. It costs us $20,000 a year to treat someone living with diabetes, and $12,000 of that is attributable to diabetes care alone. So what would it mean from a human and economic perspective, cost perspective, if we prevented diabetes? Next slide. The Y started doing just that in 2005, actually, and then we did it again in 2008. We were able to replicate that original NIH model in communities, and we did it for a fifth of the cost. And then we started scaling the program with CDC. Next slide. So I'm going to quickly walk you through the translation of the diabetes prevention program from those 2 sites at the YMCA to Medicare coverage of the program. Next slide. So our replication of the NIH DPP led us to pass legislation authorizing a national diabetes prevention program at CDC that would recognize community-based programs offering the DPP that could achieve the weight loss goal. We did this to keep the model a public health model, low cost, and one that could be replicated and taken to scale with a recognition program out of the CDC. We passed the bill as part of the ACA as a cost savings package to the legislation. Next slide. We were then funded by the Centers for Medicare and Medicaid Innovation to test this model with Medicare beneficiaries, and we were successful there, leading to Medicare coverage. Let me tell you more. Next slide. We secured the CMMI grant in 2011 and started testing our YDPP program, and we're supposed to reach 6,000 Medicare beneficiaries in 3 years who had prediabetes in 17 marketplaces across the country. We partnered with the United Healthcare Group, so they were our back-end data system and could really track whether or not we were actually delivering on the outcome. And we did it also with a host of other partners that helped us to get individuals screened and referred, like the American Medical Association and the American Diabetes Association. Next slide. I went one slide too far, but don't worry. We did serve over 7,500 older adults, and we hit the weight loss goal. And we saved $2,650 per person over 15 months in that program. And the CMS actuary released that report. Center for Medicare and Medicaid Service actuary released that report, and the Secretary of Health and Human Services at the time Secretary Burwell announced that they were going to cover the program in Medicare. This was the first ever coverage for a community-based program delivered by lay health workers. Next slide. So this slide shows you kind of our process at the YMCA for how we take a program that we have found in an evidence-based program and bring it to scale and dissemination. Today, the ones you see in orange are ones that are pretty widely scaled, and the ones in red we're still scaling, and the ones below that are really kind of more in the discovery phase. So I'm going to walk you through some of these programs now. Next slide. So this slide gives you a sense of where we are with the YMCA's diabetes prevention program. We served more than 80,000 folks through the program. We operate it in more than 200 Ys in the country in 41 states, and we do that through 1,100 sites. So a lot of times the program isn't even offered in the YMCA because it's a group-based program with a curriculum. So we're not bringing people in the Y and they're not working out at the Y, although they do have to work out on their own and track it, and most folks are more than meeting their recommended physical activity level and achieving more than the 5% weight loss. Next slide. Since 2008, the Y has worked to scale Live Strong at the YMCA, which is a cancer survivorship program. We've served more than 85,000 survivors in more than 40 states, 42 states to be exact. And Yale and Dana-Farber did a clinical trial on our program to show that it really worked. And they showed that it not only improved cardiovascular function and strength and fitness levels, but it also dramatically reduced fatigue. Next slide. CDC has supported the Y to scale Enhanced Fitness, a program that addresses both arthritis and falls prevention. And just in a few years, the Ys have been delivering the program. We have actually scaled it to 45 states, and we offer it in 634 sites and have served more than 42,000 individuals, either living with arthritis or at risk of falls. The program's been shown to save $1,000 a year in healthcare costs. And well over half of the participants, closer to 70% or higher, improve their overall strength, balance, and physical activity measures. Next slide. A newer program that we've started offering with CDC, the blood pressure self-monitoring program, is operating in 41 states and has served more than 13,000 individuals. This number is smaller because the program is one-on-one with a heart health ambassador who teaches individuals how to measure and track their numbers. A lot of people aren't taught how to use their cuffs, they're just given them, or they don't have cuffs, so we get them their cuffs. And we also help them identify triggers and participate in nutrition education classes. Next slide. We're also working to help children living with obesity, resulting in us scaling one of the most evidence-based programs available, not just in the US, but around the world. The program is called the MEND program, but we have renamed the program. We think it's better suited to be called Healthy Weight and Your Child. It's a family-based weight loss program And it was a year-long program, but that was too hard for a lot of our families. And we've actually really tried to serve more diverse families with many of our models. And so we moved it to a 20-week program, 2 times a week. And it's hard for families to do this, but the program really works. It's for the caregiver and the child, and it includes support, education, goal setting, and physical activity for both the children and the parents. Ys are trained in 31 states and are on-ramping into the program. So a lot of them put it on hold during the pandemic. Importantly, 71% of the children in this program have either reduced their BMI or slowed their weight gain, which is really the goal of this program because these kids are still growing. And I mention this program because while this is a program aimed at children living with obesity, we at the Y know that many grandparents are the caregivers for their grandchildren, and they could be part or included in this program. Next slide. Let me wrap up with just a few slides on our work with the public health system and healthcare system and at the new cohort we have going on in healthy aging. Next slide. So we wouldn't be here today without our friends in public health. 20 years of partnership with the CDC and the chronic disease program directors in state health departments. State health departments have played a really strong role in helping us to scale these evidence-based programs. They don't get enough money themselves, but they have also somehow managed to get some money out to our Ys to help scale a lot of these programs. They've also helped to convene payers so that we can talk about getting these programs paid for. We're also working and being paid for some of what I spoke about today in both the public and private health sector. We've built ways to communicate with healthcare, and it's not easy to do that. And when you have to try to work with an electronic medical record and have bidirectional referral with providers, it can be really hard as a community-based organization. And I think it's probably not the best way for our Ys to end up delivering these programs, but we are trying. We've also advanced innovative strategies to better communicate with the healthcare system and providers on what we have to offer. And we've tested a model not like what the pharmaceutical companies have with health detailers. We do health detailing around prevention directly with physician offices, so they know these programs are available in communities. Some of our Ys are serving as health hubs in order to do fee-for-service programs and to deliver not just the health programs, but also social determinants of health. But most of our Ys are not doing that. We're co-building facilities with other entities like schools, community health centers, senior centers, housing, and more to meet the health-related social needs. And we're contracting or subcontracting with Medicare and Medicaid for some of these programs. So let me turn next to our healthy aging cohort, and then I'll wrap up. So next slide. So the cohort we are working on in healthy aging has been in development for several years, but went on hold during the pandemic and really just kicked off again in 2023. It's divided into sort of 4 Ps. Principles, which we see as principles of how we show up at the Y in order to serve older adults. So what do our spaces look like? How does our equipment designed? Is it usable for older adults? How are we supporting older adults when they come in? What does our parking look like? Is there more access for folks up close to getting into our buildings? How are we communicating what we have available to seniors in multiple ways that are more accessible to them? How do we engage seniors in our boards and help them serve as volunteers or give them staff opportunities? Under programs, I kind of walked through that just now, all of the evidence-based programs that we offer, how are we making sure we offer a diverse array of that? And then in partnerships, how do we go where our older adults are so they don't have to come to us? How do we join existing initiatives? How do we co-locate our services for older adults? How do we provide programming virtually or over the phone for older adults? And then finally, the fourth cohort is just kicking off, and this is policy. And this cohort will go through November, and then all 4 of our separate cohorts, each one of these has a bunch of Ys in them, will wrap up, and then we'll start kicking off more of a activation process next year where WISE will test all of these strategies they've worked on a much grander scale, movement wide. Last slide. So this shows you the timeline that we've had underway for completing the cohort. So we should be done by the end of November of this year. And again, hopefully it should we be able to start disseminating those learnings to all of our Ys through creative frameworks that can engage not just YMCAs, but the whole community. And this design work was done and needed to ensure that our Ys have multiple quality pathways to drive and improve the health of older adults. So that was my last slide. And so I thought I could like open up and turn it up to over to questions of anybody that might have questions on the phone.
Thank
I
you,
know that was a
Katie.
lot.
Yeah, no, but it's so impressive. And I mean, I'm quite surprised really by the breadth and depth of the work that you all are doing. Karan, let's take the slides down and I will kick it off with the first question just because I can. And I mean, I have a lot of questions for you, Katie, but my first one is, how can a public health department, like what's the best way for a public health department to partner with a local Y in their community? Because there's so many programs that I think a public health department should be interested in helping to support and enhance and promote. So what's the best way for them to do that?
So, we have state alliances in all 50 states. So if you're at the state level in your public health department, I would call Katie Adamson and ask for a warm introduction because our state alliances will be eager to partner. But sometimes they don't know who's contacting them or understand the concept or whatever. And so if a state health department wants to email me and I can set up a call or I can just warm hand off to them, I'm also happy to do that with any local YMCA. Again, like depending on the Ys, a lot of our Ys are small and not all of them can offer these programs. But since we've been ramping up the virtual option, sometimes our state alliance working with some of their stronger YMCAs in the state, they'll be able to offer these programs anywhere through a virtual option. Or in some cases, like in North Carolina, our Ys will travel to deliver the program to some of the smaller Ys. So I think being able to have the right connect, I mean, I personally think you should be able to reach out to a CEO, but sometimes they're so overwhelmed at the local level. We're reaching out. Most of our Ys have healthy living program staff or community outreach workers of some kind. So you could do the local connect, but if you ever have problems, you can always call me. I'm just one person, but I'm eager to make these relationships happen.
Thank you, Katie. You're opening yourself up here. I'm sure some of these folks probably
It's
will.
fine. Yeah.
Does anyone else have a question for Katie? If you do, if you wouldn't mind turning on your camera so we can see you and ask your question. And in the meantime, Katie, do any of the Ys is caregiving and caregiver respite, is that something that the Y has engaged in or something that you all are thinking about?
It's not something that we've tracked, but it's definitely something we're thinking about.
Okay.
I think we would need the right partner at the national level. And I have talked some with the Hartford Foundation about trying to figure out who that could be.
Mm-hmm.
So I think a good model that's aligned to this is that we have sort of in the childcare realm, we have a drop off mechanism. So let's say you're a mom and you want to go work out. You're going to drop your kid off not into a formal childcare setting, but you'll be able to drop them off with childcare workers that can watch them for an hour or two when you go work out. I see that being a very similar model. We call that child watch to what we could do for a caregiver who is taking care of an older adult. We could figure out a way to build the system because we have lots of Ys working with older adults to just
Mm-hmm.
have somebody there being able to be socializing with other seniors while that caregiver gets a chance to get some reprieve. So I think it's definitely something we could build into our system. And
Yeah,
I think
yeah.
Ys would be really interested in working on that model, especially the cohort that's underway.
Mm-hmm, mm-hmm. That sounds great. Yeah, and your healthy aging 4Ps. Our model is the 6 Cs and then the age-friendly health systems is the 4 M's, and you have 4 P's, and so I love it. It makes it easy to remember some of these things. Not seeing anybody else asking questions, I'm going to keep going with this conversation. The work that you were describing around the built environment, and just making communities more, more safer and more accessible sounds a lot like what AARP is doing with their livable community. So I'm wondering if it sounds very aligned. So I wonder if there's some intentional alignment and some work in partnership with the AARP.
Yeah, and because you have been so great in holding age-friendly events and meetings, I have met those folks that are working at AARP. They've got some beautiful design strategies around what that model looks like. And years ago, when we were doing our Healthy Communities work, we actually did work very closely with AARP. If you remember, Megan, back when community transformation grants kind of ended, our work ended too, because I think that whole body of work got political unnecessarily. I think it makes total sense that one of our strategies in the healthy aging cohort is for WISE to align with current aging cohorts and aging strategies, not to reinvent the wheel. So I would very much like to connect our WISE directly to the AARP work on the ground. It makes total sense.
Yeah, I agree. I think it does too. And I think it also makes sense to connect with states at the state level, where you have your state alliances or your state associations, with the development of the multi-sector plans for aging. I really see that as another place where the
Yeah.
Y can really contribute to the changes and the policies and the systems and environments that, based on the work that you're already doing, and what can be further spread and kind of embedded through the work of the MPAs.
I agree.
Yeah.
So maybe I can ask who else is on the call so that I know who I'm talking to, and if anybody wants to share where they're from and why you were interested in joining a call about the why. Anybody willing to come off and be brave? Anybody working with a Y? I actually see a YMCA on the call. There she is.
I can share. Hey, everybody. I'm Tessa Mork. I work as the Association Director of Community Health at the Y of Metropolitan DC here in the district. And I get a lot of information about what our Y is doing, but it's always helpful to take a step back and look at what Katie's doing and kind of wrangling us nationally.
So back to Megan's question, Tessa, how do you think somebody on this call would find you?
Great question. So as Katie said a lot, the words healthy living, that's typically, we have 3 tiers at the Y, and healthy living is where a lot of this work happens. Some Ys have taken liberties with that name. For example, my background is public health, so we call our department community health. If you can find someone on a wellness team, a healthy living team, a community health team, any combination of those words, if you get anyone, they'll be able to direct you to the right person, but you're going to want to look for whoever's implementing these chronic disease prevention programs within your local Y.
And Tess, I'll put you on the spot one more time. So your Y is actually doing food as medicine. Are you involved at all in that work? Do you want to share a little bit about that?
Yeah, sure. So we have a GUSNIP grant from the USDA where we are doing a research project with Hopkins on pairing our diabetes prevention program with a food as medicine intervention. So giving folks weekly delivered produce for the course of a year, and just looking at the impact of produce provision on a health program, and trying to tie more health-based metrics into food as medicine, because that's kind of a big gap in what we're seeing in the food as medicine landscape right now.
Awesome. Thank you. And Deanna, I saw you mentioned you're already working with a Y. Do you want to, do you have to leave early? Okay, great. Thank you for sharing that though.
I can share really quickly. My name's Lanny. I work in Skagit County, Washington State. So we're up north, northwest corner of the states here. I work for a local public health agency, and we're really excited to be partnering with our local Y, who is really trying to amp up the program offerings to match a lot of the national availabilities. I didn't know about the federated model until I started these conversations, so it made a lot of sense. And we're really eager to support them in meeting a lot of the needs of our community that other partners aren't prepared to meet. So we're really delighted to have a Y locally and can't wait to work with them more moving forward.
That's great. Which Y is it, by any chance?
The Skagit Family YMCA.
Okay, great. That's so great. Thank you for sharing.
Appreciate it. And looks like Diane with the National Poll on Healthy Aging responded to your question about who she is and why she's here. So thank you, Diane, for sharing that. We've been talking with folks at the National Poll on Healthy Aging about contributing to some work that we're doing around the age-friendly ecosystem. So really appreciate your participation here.
I wonder too, maybe Megan, offline, if I could connect you with our aging cohort, if there's anything that they're seeing as a need from a survey that could be helpful. I don't know, but it might be worth exploring that.
Yeah, absolutely. Absolutely.
Anyone else want to get off and talk about themselves and how or why they might want to work with a YMCA? Come on, brag a little. What are you doing out there?
There's so many opportunities. I feel like every time we do one of these trainings and we learn about something that, or, you know, a program or a partner, it's kind of sometimes, you know, a little bit hard to absorb it all. But Diane, go ahead.
Yeah, I just didn't know if there's a way to share, we would like to share our data with you or with your membership. I don't know how that looks. You have electronic newsletters. We could,
Oh, yeah. Oh, yeah, absolutely. In fact, we have inside of the Y, we have what we call peer networks. So we host monthly calls with a chronic disease and social determinants of health peer network. It's about 100, 120 of our leaders in the Y movement that are really focused on the next big thing in chronic disease or social determinants. We could have you present some of that on one of those calls.
That would be terrific. Thank you.
Yeah, absolutely. Megan will connect us.
Megan, okay. Great.
Yeah, yes, Diane, if you'll, I think we probably have your email address. Cron, is that correct that we would have Diane's
I'm
email
also
address
just putting my
registration?
email address right there into the chat.
Okay,
So you can email me
perfect.
directly.
There
Thanks,
we go.
Katie.
Thank you,
Perfect.
Katie. Thanks,
Yep.
Diane.
And we have similar cohorts in housing, and we also have
Wow.
we have networks and innovation cohorts and pretty much any topic you can imagine. Since the pandemic was over, we started building these peer networks so we could take the best practices and further test them and innovate them, and then drive those innovation out to the movement. So from after school to healthy aging to housing to food, we have cohorts working constantly to innovate.
That's wonderful. And do you work with Meals on Wheels at all, or is that they've got their own, you know, their own process within
They
the
do have
community?
we definitely did during the pandemic.
Okay.
We would like to do more in that
Mhm.
space, but I also think that the money is tight, and the Y
Yeah.
always tries to, we don't want to move in on somebody else's turf unless they need
Right,
us.
right.
I know there's a need. There's not enough money out there.
Mhm,
So
mhm.
I know our Ys raise money and get donations for food, period, because the demand is so high. Like right now, post emergencies in North Carolina, from the 2 hurricanes, we have Ys across the United States donating hundreds of millions of pounds of
Wow.
food down to those areas because there's no water still in areas in North Carolina.
Mhm.
So we're donating water, food, and the trucks are being sent from Boston. That's the kind of special thing about the Y movement, that we're responding to from across the country to the area that is needed. And our Ys are serving as emergency response hubs right now, where the folks that are rebuilding communities are sleeping at the Y. Some families are sleeping at the Y. People are showering at the Y, where we've got water working, where we put kids in childcare at the Y so families can deal with insurance. So what happens in any emergency anywhere in the world, because we're in 120 countries, is the Y becomes the place people go to recover. And so that's a special thing about our movement, I think.
Yeah, yeah. Well, I'm inspired to go visit my local Y. So everything that you've said is really, really inspirational, and you can really tell how passionate you are, Katie, about this work as well. So really appreciate you being here today.
Anyone who's in the Washington, D.C. area, if you've never been to our Anthony Bowen Y, it's up in like the W Street area. And the street's named after Anthony Bowen. It was our first African-American YMCA, and it was built by Anthony Bowen, who purchased his freedom as a slave. He purchased his freedom for $450 and built the very first African-American Y. And it took an act of Congress and the president to allow the affiliation with a white organization. And if you go into that Y, you will see the history of the Underground Railroad in that YMCA. You will see that Brown versus Board of Education was written there, that Langston Hughes wrote poetry there, that Duke Ellington played music there, and there are instruments hanging from the ceiling. And the Y itself was painted by the folks that painted Busboys and Poets to tell the whole history of the African-American movement in the DC area. So it is in and of itself a beautiful YMCA, but it is a special, special place in the Y movement. So if you're ever in
sounds
town,
like, yeah, it sounds like a museum, just another museum. Yeah,
it is.
Very special one.
Yeah, we turn 175 next year, and Anthony Bowen built that Y, I want to say in 1856. So that just tells you how long our tradition and history has been in trying to work on equity in this country.
Yeah, that's amazing. Amazing. Thank you for sharing that story.
1853. Thank you,
1853.
Tessa.
Yes, thanks, Tessa.
I was close.
Yeah. Really, really appreciate this, Katie. It was great to have you here today. Love reconnecting with you, and we will be sure to continue the conversation about how public health and the Ys can support one another, work together, because we're all trying to do the same thing. Our ultimate goal is really to support the health and well-being of older people in our communities. So, thank you for that.
Having me.
Absolutely, Karan. I'll turn it back to you to wrap us up.
Thanks, Megan. Thank you so much, Katie. I actually was looking up the YMCA as you shared it, and I will probably stop by one day. So
that's awesome.
That's awesome. Sharing that. It's a great resource. Just to close us out, our next training will be November 21st at 3 p.m. You'll be able to register for this under our event section. The training topic will be about tribal communities, specifically tribal communities in Washington State, and we'll talk about partnership between public health and a Northwest Washington Indian Health Board. So look for that in the very near future. And if you are trying to become an age-friendly public health systems champion, please navigate to the website or use the QR code to document that you've attended this training. If you are viewing this as a recording, please pause the recording now so that you can note you have attended this training by linking to the survey included on the slide. And with that, we thank you for attending today.